Good evening, everyone, and welcome to the July meeting of the Academy of Integrative Health and Medicine's Cleveland chapter. I'm Peter Geller, co-leader of the chapter, and Dr. Amy Cipolla, our other co-leader, is here as well, and she is helming the Zoom and doing all the great tech things that I'm incapable of doing. But she has many, many other values besides that. And Amy is the one who actually organized tonight's webinar, invited our esteemed speaker. And so I'm going to, in a minute, turn it over to her to do the honors, do the intro. I just wanted to say one quick thing is that we have a lot of people who signed up for this, and people from really all over the world, all over the country, which we often have a good cross-section of that. But this just struck me particularly. And I think it has a lot to do with both the topic and the incredibly diverse background of our speaker, which I'm sure that if you read about it in our newsletter or any place else, in a poster or wherever, you would have seen some of her credentials and experience and been attracted to the webinar for that as well. So that's really all I wanted to say at the top. And Amy, take it away, please.
All right, great. So, again, like Peter said, we're so happy to have Dr. Robin Austin here. She is Associate Professor at the University of Minnesota School of Nursing and Director of the Center for Nursing Informatics. She has more than 20 years of clinical experience in pain management, women's health, and integrative health, with a DNP and a PhD in nursing informatics and dual training as a chiropractor and a nurse. Her research integrates data science methods to address whole person needs with a focus on chronic pain and menopause in midlife women. Dr. Austin is a research mentee with the Menopause Society and a fellow of both the American Academy of Nursing and the American Medical Informatics Association. So thank you, Robin, so much for being here, and we'll let you take it away.
Sure. Thank you so much. I really appreciate the invitation, and I'm excited to share some of the work that we've been doing over the last year. And some of this is the first time I've been able to present some of our results. So I'm super excited, and we have a couple papers that are pending that I'll share that as we kind of get in. And so I'll share my screen. Here we go. And I'll make this much larger here. There we go. So this is just, again, we're bridging the technology for whole person health and across the menopause transition. And I'll share really what that looks like throughout kind of the research that we've done and how it all fits together. So here's just our brief agenda. I'll do a little bit about me just because I think it's always interesting to see how people got to where they are and what they're doing now. And so I can share a little bit about that. Also really kind of diving into the intersection of menopause, whole person health, and technology. What does that mean? We hear about these things in various different spots, I think, but not always all together. And then I'll share some of the informatics enabled research that we've been doing, and then hopefully time for discussion and dialogue at the end as well. You will have access to these slides. I will make sure of that in case you have more questions, or I tend to skip around potentially at the end. I want to make sure we have time for enough questions. And so if I speed up a little bit at the end, that's why you'll have access to these slides. So as I mentioned, my background is kind of varied, and kind of coming to what I did today was not always a linear path. But I did start with my undergrad degree is in exercise science. And from right after undergrad, I went to do chiropractic training. For me, I thought it was a great transition. I love the idea of doing like less is more and very non-pharmacological approaches. It's really kind of at the heart of what I love to do and what I love to treat people. But from there, I also realized I wanted a little bit more about health and healthcare. And for me, it was a natural transition to go in to get my nursing degree. And so I did that, and you can see in 2024, and then shortly thereafter, I did my master's in nursing. But I was an operating room nurse by background, was kind of my segue into nursing. But when I was an operating room nurse, at the time, our ORs went paperless with our technology and documentation, and I thought it was super cool. And I realized nobody else really wanted to do it. So they said, if you like it, you do it. And that was kind of my bridge into what we now call informatics. I didn't know it at the time, but I love that we could have technology to let patients and families know out in the waiting room where we were actually in the process of the surgery. I think it eased a lot of anxiety, and I thought, if technology is here to stay, what else can we do and what's going to be on the horizon? And I wanted to be a part of it. So that led me down the road of getting my Doctor of Nursing Practice and then subsequently my PhD, both focusing in informatics. And I really took the lens of not only nursing and how do nurses use technology and data, but what does that mean for patients and families? And so I kind of focused more on that consumer health informatics engagement piece. And that's kind of what subsequently led me down the path of where I am kind of today as well. And I'm sure we can't talk about technology without talking about AI, which we'll get to in a way, in a roundabout way that we'll get there as well. But that's just kind of been my trajectory and kind of my pathway through that as well. But I'm happy to chat more if you have more questions about that. So I really wanted to focus on this specific spot. So menopause, whole person health, we hear a lot about. Menopause is obviously in the news much more today. It feels like my whole thread of either LinkedIn or Instagram is filled with menopause topics, but then also bringing in the technology piece. And so what sparked my interest in this, not only personally down this health journey, but also how do patients deal, or how are they managing their symptoms? And how are we representing menopause through health data? From that informatics lens, that's the part I wanted to kind of get at, and realizing that there's not only lack of research and lack of data around menopause and midlife women, but really how we represent that and how we represent menopause symptoms within healthcare data is severely lacking. So my whole kind of approach in the last few years have really been to how can we make women's lives more visible through whole person health informatics and really represent the whole of the person, also including the context in which they live and their lived experience, which I think is often an afterthought after the fact, or if asked at all. And that's just kind of how I wanted to give a visual picture of some of the research that I've been doing. I won't spend a whole lot of time because a lot of people probably already know this, but menopause is certainly, I think of it, and midlife in general, as a critical window into health and healthy aging. I love the idea of the iceberg that you see here. What we see on top is kind of all the signs and symptoms, but really down below is what we don't necessarily see or talk about, which is osteoporosis, bone loss, cardiometabolic issues, cognitive decline, all the risk factors that tend to live below the surface. But on top, we see hot flashes. I'm not sleeping. I'm gaining weight and I don't know why. I'm beginning forgetful, all of the things. But really, I think the part that is most striking to me when I started kind of diving more into this is that women really spend a third of their lives, or almost a half sometimes, in postmenopause or a life after menopause. And that has serious, I think, health consequences that we really haven't given credence to. So I'm thinking now of midlife as such a critical window to how do we set ourselves up for healthy aging into the future, and we can live independently as long as possible, and to also try to ward off a lot of the health risks that seem to be prevalent around older adult women. And so I'm not going to, also the whole person health, a lot of you have heard about this and know the definition, but it really takes into a person's account the environment in which they live, their physical signs and symptoms, psychological aspects, and also their health-related behaviors. And so that's really been the framework that I've used through a lot of my research to really make sure we're just not focusing on the signs and symptoms, but really it's also where somebody lives. Their health behaviors obviously have a huge impact on how they live and what they do, and also in how they healthy aging specifically. And also the other part that I've been very interested in is this: how does someone's strengths or their resilience play into their health? We know people come with assets and they come with a lot of strengths, but how can we have that a little bit more part of the health conversation? We know people are resilient, but how do we have that maybe potentially to leverage health challenges that they have throughout their lifespan as well? So whole person health, but in addition to taking in their strengths, has really been a big, I guess, framework for my research. So that leads us down the road of technology as well. So where does all of that fit in? Also, we have a whole plethora of wearable technology. How does that integrate into our health? A lot of people have the Oura rings. I wear my smartwatch. I have health apps, but also that there's been a few reports out, and I put some QR codes on the slides to give people quick access to some of the reports that I'll be mentioning. But there's a really big gap that they've identified, and it's around women's health. And how can we then use technology, or what's also called feminine technology, or femtech for short, which is really technology that's focusing on women's health specifically. And I'm more interested in the ones around menopause and midlife women. But it's really, they're saying it's a once in a generation opportunity to use femtech to really redesign women's care that's been missing for a very long time. And how can we then connect a lot of these pieces that we're talking about, women in the context of which they live, their signs and symptoms experience versus just episodic care that we have, which may be every 6 months, maybe once a year, whatever it may be, but really shifting it towards more of a continuous process, potentially with a lot of the wearable technology that we have. So innovation, I think, is going to come from not only these digital tools, but how can we get these tools integrated into clinical care and clinical workflows? That also really represents interoperable platforms, meaning that there's shareable and comparable across health spans or across, I would say, health systems as well. And the big thing for me being in informatics, I realized that the infrastructure that we have is really not there yet to support women and from the data. And so really that there's another huge opportunity. And a lot of the work I've been focusing on is really how do we build that infrastructure and have better and build better data systems to support women. Specifically when I'm thinking down the pipeline of AI and AI technology, which I'll get into that in a little bit. There's another, I think, paper that I thought was really interesting is that they were measuring whole person health. And so someone did a scoping review of these individuals, but really what is whole person health? How are we measuring it? And you can't necessarily, I think, improve it unless we know how to measure it. And so I thought this scoping review did a very nice job, I think, of just looking at the broad kind of swath of what are some of the tools that are out there? How can we better represent and start measuring whole person health? And they realized that no current measure was broadly for all purposes. I know the VA has their own measure. There's a couple other whole person health indices that have come out. But really looking at there's commonalities across all of them, but nothing kind of is a one size fits all. But if you're interested in more about the measurement component of whole person health, certainly take a look at the scoping review. I thought it was a good paper just to give everybody I guess a framework or found a starting point of where we are at right now at this time in science. Another work that I did with another group is that we were basically looking at advancing whole person health through informatics. And this group is really from an informatics, very data-driven perspective. And what are some of the knowledge resources that currently exist? And a lot of this work did include some genomic data, as well as some other nutritional data, but also from physical science and physical, I guess, interventions is what I'm trying to say, and then the psychosocial components. So really, this was just, again, a broad needs assessment. What do we know about the current resources that are available to help us move this science forward from a data perspective? And it was really interesting work, specifically looking at more of the genomics pieces, I think are a little bit more advanced in some regards, but I think there's a lot of room for improvement around integrative therapies, I think, to have data representation and to start marrying, I think, the big world of big data. How do we then put together a lot of these bigger data sets that are looking at populations using integrative therapies, and how can we do bigger, broader studies, I think is really what the crux is. If you're interested in that from a very informatics data-driven perspective, that's another paper I would recommend too. But the reason I bring up data is just to kind of set the foundational part of really data quality and data harmonization. And that I keep going back to that because specifically for midlife women and women in general, the data has not been great. And so really it's a big part of this is going to be how do we harmonize data? Everybody's collecting things differently. Everybody does something a little bit slightly differently. And I had a student who had talked about it from looking at it from ingredients in a recipe. So depending on your ingredients, are you talking about it in cups or in milliliters? It's the same thing when we talk about documentation. So I think of it from, are we documenting a patient's temperature in Celsius? Are we talking about how do we write it? Is it just a T101? Is it a temp 108? Well, is 108, is that mis-entered? Is that up from maybe a 104? There's lots of ways to look at this. And so again, we're all kind of collecting data slightly differently, and it's also represented differently. So how do we harmonize all this data across? And I think my key point really is that bad data really now in our health systems that we have in the data infrastructure it doesn't just sit there. If we're using and building tools using EHR data, which we are, or other data, the bad data can potentially lead to bad decisions. And so for me, that will affect patients. And so I think for me, going forward, getting a better, cleaner data pipeline is going to be absolutely essential. And also realizing the limitations of the current data that we have, specifically around women and midlife. I just have to bring it up just because it's a big crux to what when I talk about with data. Just making sure people are very, very aware, because also the data we have could be biased. And specifically, that's very highlighted in women's health research. The other piece I want to talk about is when we think about electronic health record data, a lot of what we have might not be in structured fields. So it's harder to get the data out for research, but a lot of data might be hidden in a clinical note, which is very, very typical. We put things in a note. If we don't have it in a field to put into, we'll put it into a clinical note. Well, the clinical notes are harder to get data out of. And so you can look at a clinical note on the left-hand side of the screen. You kind of see the messy data piles of information there, or the standardized data on the right-hand side where it's very structured, it's standardized, it's cleaner. And so yet we have these two kind of buckets of data that we're dealing with. And sometimes it's not always clean, specifically the clinical note data, needing to use other methodologies to get the information out of that, because it's very rich information. I think that's where a lot of, I think, our context lives within the clinical note for patients. And so how do we grapple with this when we're trying to look at getting the best of our data, knowing this is where things kind of sit and look for? I just have to have the visual out there, because the clinical notes to me are what on the left-hand side, where it can be very, very messy, versus standardized data on the right-hand side. So again, kind of going back to what we've been thinking about for women's health is that how do we build a better infrastructure or a pipeline for a lot of this work? And so previously we had an order from the previous administration on executive order women's health research, really had a executive order really to look at how do we expand and represent through common data elements for specifically for midlife women. And I got super excited seeing that. Being an informaticist, I was like, well, this is perfect. This is an executive order saying exactly what I want to be doing. Unfortunately, that executive order no longer is in existence, but I went forward and looked at, there's a new appropriations bill that came out in 2026. Lo and behold, there is a common data element for women's health. And so I thought that was another win, that it's still there. There's still a call for getting better data for women's health. And so that's, again, I think, reinforcement for some of this work that we'll be doing. So kind of now jumping into some of the work that I've been doing and where I've been kind of getting my, I guess, ideas and building off of what I've done before, is my colleague and I, this is actually during my dissertation work, she said, let's create an app. And I was like, sure. But she said, let's use standardized terminology to create the app and really to represent whole person health. So we created an app called My Strengths, My Health, or it's really a self-reported assessment tool. It's not an app, you would say, it's like a web-based assessment, I guess you could call it. And we translated the terminology from the standardized terminology that was there into what we called simplified terms. These were community validated terms at the 6th grade reading level. We wanted it to be very health literate or appeal to a lot of folks with maybe potential health literacy limitations, but also on the back end that this is already standardized terminology coded within what's called SNOMED CT, which is an international terminology. So that was kind of the idea for building this app, whole person health focus, and I'll share what that means in just a second. So we developed My Strengths, My Health in 2017. If you're not familiar with the Omaha system, it is a standardized multidisciplinary terminology, which is based on the app that we had created. And I circled the 4 domains of health, which is kind of what is centering on this framework, which is the environmental domain, psychological domain, psychosocial, and also health-related behaviors, which is essentially whole person health. So that's kind of what we designed this assessment tool around, for people to self-report health challenges and health needs. So here are the terms that we have that are from the terminology based on these 4 kind of domains in the application. And I'll share a screenshot what that looks like in the live kind of in the app itself. And so we wanted people to see, could we feasibly have people self-report their whole person health in an assessment tool, was kind of how we started out thinking about this work. Again, really centering on these 4 domains of whole person health. So this is what it looks like. I'm looking at the pain concept specifically. So people were able to report specific signs and symptoms related to pain. So are you currently having pain? Do any of these or any of these apply to you or not? You could select any or all, and then you provide a rating. And how do you currently rate your pain? Is it on a very bad or no pain scale? And then to what kind of needs do you have around pain? So you're able to say, I need someone to check in with me. I want more information and guidance around this concept, or none or no needs. And these are the same kind of similar self-reported challenges, a status rating, and then self-reported needs across all of the 42 concepts that are in the app itself. So we were able to use this specific tool in various community settings. And I used it for my dissertation research. And I have a picture of Goldie Gopher because we piloted this app at the State Fair of Minnesota in 2017 with great results. And so we were able to capture whole person health data from community dwelling individuals. And from that, I was able to then do some analyses of what does that look like just from a community perspective, or individuals, broad kind of varying participants that use the app for my dissertation work. And we actually then from there were able to work with our community partners in various community settings throughout a couple of years in various populations as well. And you can see some of the studies that we've done. But having the structured data on the back end, we were able to apply some additional methodologies such as machine learning methods or data visualization methods to really see some different patterns that we may not have been able to see just through regular statistical analyses. And so over the year of using the app in various settings, we had accumulated a pretty large data set. And so from that data set, I said, well, what do we look at? Could we look at women across the reproductive lifespan? And so from that's the current study we just completed, is that could we look at women that were from this larger data set that were of reproductive age, midlife, and older adulthood, and then look at do they differ? Are they similar? Do they have similar strengths or health challenges or health needs? And so just kind of getting an idea of this could also potentially future-wise, we were thinking, could this lead to more personalized, tailored interventions? Because these are very different age groups and they have very different health challenges and potentially resilience kind of with it as well. So we did this the last year or two, we've been working on this study and we just kind of looking at our results. And so this is a little bit of a busy slide, but I wanted to try to showcase that you can see the domains on the left-hand side. So it's self-care, my mind and networks, which is the psychosocial domains, my living, which is environmental domain, and then my body, which is physiological domain. And so we can see that then the health concepts kind of in that middle column, they're very broad. This is again the entire population, the entire data set of the 706 women that we looked at specifically. Whereas health challenges that came up frequently or exercise came up quite a bit for all groups. I'll share that in a minute. Sleeping, nutrition, socializing, income was another one that came up quite a bit as well. But also some ones that I hadn't really considered specifically was that pain was definitely there, but skin, digestion, other things that spirituality and faith, but also grief and loss were part of that. Some of the health challenges that were reported as well. Then we did a deeper dive and analyses into specifically looking at the different groups. And so were there different challenges, different health needs or strengths across each of these groups? And so the top challenges for both groups was exercise. And specifically the reproductive age group said that they did not exercise like they should. And then the midlife and the later adult group said the exercise plan was not adequate. And so looking at those two specifically, are there specific interventions we
I think Dr. Austin froze. Peter, is she frozen on your screen as well?
Yeah, it looks like the whole thing just froze.
We'll just give her a minute here. All right, hang tight. I'm guessing it's her internet, so she'll be back just in a moment. In the meantime, I already put it in the chat, but if you aren't already on our chapter email list, you can sign up. I put the link in the chat, and we send out event notifications and we have socials. So definitely, we'd love for you to join our chapter newsletter.
Hi, sorry about that. I'm not sure if my internet went out or what happened, but I'm back.
No.
Sorry about that.
Perfect.
Oh
No
my
problem at all.
gosh.
That's what we figured.
I was just emailing you like, I don't know what happened. I'm talking and all of a sudden it went away. So I will
Yes,
jump right back in and share my screen, and I think I'll pick up where I was. I'm not sure, but that's okay. No big deal.
that sounds good. Thank
Okay. Sorry about that technical difficulty. I will just skip right to the conclusion and then continue on with a few of the other projects I was doing to make sure we have time for Q&A as well. So sorry about the glitch. So I guess just conclusion of some of the research that we did, that there's a paper that's coming out regarding some of the work we just did around the three groups I had mentioned as well. But we really realized that standardized structured terminology really helps us to understand the more perspective of whole person health, and how can we better leverage some of these the self-reported tools that we have for further research or for further work into clinical work would be another key component. And the personalized intervention findings that we found have really an opportunity to dive into more with specifically around the exercise and income would be another key component. But I think the biggest takeaway was that until we really invite individuals to offer or self-report their whole person perspective, we may not know some of these insights that we've been finding as well. So exciting work, and hopefully the paper will be coming out soon. Fingers crossed. It's under review right now. So I'm going to switch gears and talk about some of the work we've been doing specifically around menopause representation and data, and also the documentation of this data. And so I'll just kind of share a few of the projects that we've been doing. And then I'll end with, we did a study just recently on what do women really want from technology, being that we have a lot to offer, but what is really the need around that? So we did a project looking at, there's various menopause related, I would say, scales or validated assessments. And so what do these tools have common that are common across all of them, but really none of them are represented with a standardized terminology. Again, going back to really trying to create some data standards or common data elements specifically for midlife women that everybody should be collecting on eventually in the future is my goal. But we looked at 6 different checklists, and I put them basically all in a spreadsheet. And then we mapped these 293 items to the standardized terminology, the Omaha system, which also these are now also represented within, it's already mapped to the international language called SNOMED CT codes. And so from this, We mapped everything out from 293, and then we deduplicated that large data set, and we found that there were 72 signs and symptoms for 21 problems in the Omaha system, which there's 42 of them. But what we also realized that there's some semantic differences when we look at when we get down to the very granular detail of signs and symptoms for specifically menopause, because it's very detailed and there's so many different signs and symptoms. What we realized is that sometimes there's not always a correct match. So for example, in the skin problem, it did not represent that women were reporting increased facial hair or thinning of hair or changes in their skin tone and texture was not necessarily represented within a standardized terminology. So we're getting really, really quite granular, but we have to have a way to represent this data in order to have a better showcase of it. So that was one area that we found that was a gap. The other gap we found is that pain, specifically the pain problem, there's pallor and perspiration is a sign or symptom within the pain problem, but it does not necessarily match for when we talk about hot flashes, sweating, or night sweats are very different when you look at pain, and you're sweating from a pain is very different than sweating from night sweats or sweating because you have hot flashes. So that's, again, another very granular detail that needs to be, I think, looked at, and how do we accommodate for that to make sure we're really representing and we're not just generalizing and lumping things together when it's semantically they're very, very different. So that was one of the key findings, and we wrote a paper about that a couple of years ago. The next project we did is then looking at some of those, we looked at signs and symptoms, but now we want to look at what are some clinical guidelines. And we have a lot of clinical guidelines around menopause, and there's some recent ones that just came out as well. But we found two that were rated high quality, and which is from the NICE menopause guideline, which is from the UK, and the Malaysia clinical guideline. These two were from a systematic review. They were rated very high. And then we took two position statements from the Menopause Society around hormone therapy, and then also non-hormonal therapy as well. So we took all these guidelines and put them basically in a huge spreadsheet and said, how do these map to, again, a standardized terminology to make these guidelines then computable, which then could be entered into a computer, an algorithm, or clinical decision support tool in the future. This is kind of the foundational work in order to get things to be computable. And so you can kind of see the flow guideline that we looked at, all four of these statements, putting them into somewhat standardized terminologies, which then would be a computable code eventually down the road. So we had around 220 of the guideline source texts, which we then had it basically mapped to 76 unique combinations. But then when I had the finalized guideline, what we thought was finalized, reviewed by a clinician as well. And so there were some differences that what we had interpreted versus the clinical review person at the very, very end. And you can see that there was a couple of them that we changed based on the recommendations from a clinical perspective. But all in all, we had 76 unique kind of interventions that were computed for this guideline. And you can see there, the main problem within these guidelines was obviously reproductive function, followed by circulation, which I thought was quite interesting. Mental health came up quite a bit in all these guidelines, and then neuromusculoskeletal function as well. So I think to me, some of this showcases the varying ability in various, I would say, systems and functions that menopause can affect. That we don't necessarily, we think of just more of reproductive functions, but really truly that there's cardiovascular, there's mental health, and there's also neuromusculoskeletal changes that occur as well. And then the most, I guess, intervention was case management that was represented within this guideline. And that, I think, speaks to how we kind of, I think, care for menopause. A lot of it is case management. We're just kind of trying things, waiting and seeing, and then maybe needing adjustment down the road as well. So it gave us a really understanding of where things are, I think the guidelines are going, but also what is missing from these guidelines. And I would say that what's missing from the guideline that we found, and this will hopefully come out in one of the papers that we have, is that the environmental and some of the psychosocial is missing. Yes, mental health is featured here, but a lot of the other things around psychosocial components, around social isolation, the importance of social connections, I think just coping and grief and loss, some of the other components that were not mentioned, and also in the future, the looking at how do environmental factors play a part of menopause as well, and some of the maybe some environmental factors that could also have neuroendocrine function changes were not necessarily included in these guidelines, but maybe in the future. This is just a schematic diagram of where some of the health conditions or the health problems came from, and then what are the interventions in the middle, and then some of the specific targeted interventions that were given throughout the guideline. I think too, I was trying to find a pattern in the guideline, but the pattern is that there's no pattern, only because that there's varying lots of things going on when we're caring for women with menopause signs and symptoms, because they're so varying and so vast. Trying to get everything into a standardized structured format is really, really challenging, but I think it can be done with a lot of nuance and really paying attention to some of those very semantic details to make sure we get it correct. This last project that we did was really looking at, our question was, how is menopause being documented in the electronic health record? How are we capturing this data, either menopause status and/or signs and symptoms? I go back to the picture I showed very at the very beginning of the data that is kind of very messy, and that's exactly how I think of menopause data, is that it's either hidden in a note somewhere or it's not documented at all. But from this project, we found that there's lots of gaps in documentation, very little much on menopause status, and a lot of these studies were using menopause as a proxy, meaning that they were using an age group, which happens often because it's not staged specifically. There's no standard. There's a standardized way to stage menopause, but it's not documented that way, is what we've been finding. So that could be one takeaway, that how can we change that clinical practice to just document maybe final menstrual period, for example, versus just using always an age by proxy to really study women within some of these data sets. And symptoms are, again, I'll skip to the next screen, is that we found major 3 themes from this work, is that there's documentation limitations, meaning that the documentation systems that we have are not set up to really have a structured field to document final menstrual period, or to really classify any of these, specifically the staging of reproductive aging. Certainly of menopause, there's documentation of symptoms, but then when they tried to follow it a clinical guideline, the treatment sometimes was missing. And so there is a disconnect between maybe documented symptoms, but not followed up with treatment. In addition, that there's underreporting of symptoms. Maybe there's a discrepancy between, that they found from some of this data, is that the discrepancy between what the patient was reporting and then what appears in either the EHR or claims data. And so that could be that varying reasons, right? There's lots of that. But again, these are 3 kind of major themes that we found from some of these studies that did use EHR data to examine menopause. So lots of room for improvement on this, I think, as well, looking at it from how can we get better data and kind of cleaning that dirty data pipeline to get better data quality, to have better representation. I'm going to skip over this because this is just the conclusions, which we've been kind of talking about throughout already as well. But I wanted to skip to the project that we just kind of completed around looking at technology needs and preferences of midlife women, but also health providers. So we did kind of parallel surveys around midlife women, what are they looking for? But then also we asked providers as well to make sure that, is there an overlap, and where can we get better, I would say, workflow to integrate some of this data in a better way to represent this midlife women. So we did a cross-sectional survey it was actually last summer, August to October. We recruited through social media and Facebook to have women answer a few questions around menopause in general, and what kind of technology needs do you want, or what are you currently using? So we had 107 participants. 68% were currently in perimenopause, and almost all of them had reported at least one menopause symptom. 80% of them were using a health tracking device almost every day, or 2 to 3 times a week. And participants were very likely or somewhat likely to use both a symptom tracking and a lifestyle coaching tool, that they wanted to be able to have both of them within one app. So that's kind of just some of our demographic data from that. But what was really interesting is that the most valued digital tool features that they said is they wanted to be able to have biometric data, symptom tracking, but also they wanted evidence-based information. That came out pretty strongly, that they needed to have information that they could trust, in some of these tools as well that they're using. And that barriers to use is not too surprising, is that the complexity or usability issues that they were it was over 50, almost 50% of them said, I'm out, I'm not using it anymore. The cost is a factor as well, but also privacy and data security was a big concern. Again, not surprisingly, considering that this can be very sensitive health information, that they want to make sure that that is safe and secure. But I would say that 91% or 91.7 were willing to share at least one type of health data for research. And so most likely that they wanted to use menopause symptoms and lifestyle data were the most common ones. But the other piece that was interesting is that not only they're willing to share data, but they wanted to be able to have control over what data is shared and with whom. So they're more than willing to share, but they wanted, again, be the ones to have control over that data, which is interesting. I didn't report it out here, but also they're willing to share the data. They want control over the data. But when we did ask if they read the privacy policy statements within health apps, a majority of them do not read the privacy policy statements, which isn't surprising. I don't. They're very heavy. They're very dense. It's legal jargon. But again, I think it's really important to understand how some of the health apps are using or potentially using the health data that we enter into these apps. Is it being sold to third parties? I think we have a right to know that. And is it truly de-identified? I guess those are my two big questions that I would have. But really interesting insights, I think, when you're thinking of how do we develop technology to better support women, that having these features, that the control over their data, making sure and that it's evidence-based and that we have the ability to have privacy and secure data are three of the big things that I took away from some of this work. So on the flip side, we did a study with the health providers saying, okay, what do health providers want from technology? How are they using it? Do they even care that someone comes in with their, my health tracking data? Do they want that? Do they not? So we did a follow-up study with just healthcare providers, specifically that were caring for midlife women. And so our final analysis, we had about 99 providers, which I thought was pretty high, because sometimes getting provider insight can be challenging. But you can see the breakdown of the types of providers that were involved in this study. But you can see that a majority of them felt somewhat confident in kind of helping women with menopause signs and symptoms. But I can see that, so what types of menopause-related education or support would you find most helpful for your practice? And they really wanted clinical guidelines and algorithms. They wanted EHR documentation templates, which came up in a couple other areas as well, which I could see that. And then patient education handouts that were also evidence-based. So there is that overlap of wanting healthcare providers wanting evidence-based information, and same with patients as well, or women. But really what's interesting to me is the wanting the clinical guidelines, algorithms, but also they really wanting something concrete with already built in within the EHR. So that means to me, we have a lot of opportunity for improvement around clinical workflows that we could certainly change a lot of the practice that's happening now. So the other part that was interesting, I thought, is so what types of patient data would be most useful for your practice? And I was thinking they'd want what's third on the list, which is menstrual patterns, specifically for midlife women. But really, it was they were asking for, they would have much better, wanting more useful, is having mood or mental health data, and then sleep quality and duration data, which again, it's not surprising, but it is surprising. But I think that would be maybe another piece to the puzzle to really kind of encapsulating all of what whole person health is. So we can report on menstrual changes, sure, but really it's the things that we might not capture in a regular, I would say, clinical visit sometimes is mood and or specifically sleep. Maybe that's not asked about, you don't have time, but that's really patient data that'd be very, very useful in clinical practice when you're putting the whole piece of the picture together as well. So I thought that was interesting. And here's some technology preferences. I'm not going to go into too much detail of this, but here's some what they would find for digital menopause tools. I think this is, again, I think we can do better. I think that this is a huge opportunity that we could integrate within clinical practice based on what providers are seeing and saying. And so huge opportunities, I think, specifically for patient summary reports, but also that risk factor visualization. So what not only is somebody at risk for bone health, but our cardiovascular health, but could we give the provider and or the patient a tool or a visualization that would really, I think, bring home the message in a way that's approachable for both. Integrating with the EHR, again, evidence-based clinical recommendations at someone's fingertips. Alert reminders, again, low on the totem pole. I get it. We have alert fatigue. all of those components. But I thought this was, again, insightful as we look to how can we better develop technology to help both within clinical practice. So my next steps, I know I have about 10 minutes left. Developing some common data elements is another big kind of piece of work I'm trying to capture, just because that would be very, very helpful if we had everybody collecting on these 10 things, for example, across health systems. We might be able to collect better data longitudinally as well across health systems. For me, I go back to high quality data is absolutely essential for future AI development. If we're building data or tools on data that is not great or already has gaps, I worry that some of these gaps are going to be reinforced. And then currently my last piece of work is that we're revising the My Strengths, My Health tool, and we're doing a separate version specifically for midlife women. So it will be much shorter, a tool potentially, and then really focusing on kind of what we've been finding through some of these other previous studies. So with that, I will thank my team. I have PhD students and colleagues that have been helping me with this work as it continues to kind of grow, and I meet more colleagues to be able to share some of this work as well. And then I'll just say here's my my QR code for the LinkedIn if you're so interested. And then I would say that the image it's like a caricature image that I did through ChatGPT. Just because I thought it was funny, I had to share it. So that's it. So thank you so much for having me. Again, I apologize for the glitch in my internet for the moment, but we came back, and so again, I thank you. Hopefully this was super helpful.
Thank you, Robin. And if anyone has questions, you can type them in the chat. I have a couple questions I'll start off with since we don't have any in the chat yet. Working in women's midlife, I would say, a lot of the research funding, I just heard a podcast about this, is going in women's health goes to like pregnancy and like focus on reproduction and cancer. And in your research, I thought it was interesting that in the guidelines, like 40% was about reproduction in midlife. And do you think part of that is just because of where the funding is, or like why do you think there's that focus on reproduction versus all the other symptoms, which are more disruptive and like based on your other research, not necessarily a top priority for women?
Yeah, I think too, it's been based on what we've done so far already, which is what, kind of how things have been. I hate to say it that way, but it feels like women's health, you're either focusing on adolescence and puberty or pregnancy and postpartum. And those are two obviously important things in women's lives throughout. But I think that we're finding the research dollars will hopefully catch up soon with how we're finding that how midlife is so critically important for healthy aging. And it felt like there's a lot of research on older adult women, but there's this gap in midlife that we're not really seeing the trajectory of how important and critical window we can do and kind of capture and prevent things upstream before waiting until we're 65, which again, like the bone density scan, why do we wait till we're 65? To me, that's insane. But like we have to wait for policy to change to cover the cost. You know what I mean? So things can take a while, but hopefully it will start to catch up the more research that's coming out. There's some really phenomenal researchers, Pauline Mackey and Rebecca Thurston, doing some awesome work. And so I'm hoping some of their findings will lead to further dollars. And I think, looking at the current mechanisms, how could we frame, I guess, some of the work that we're doing? Because there's a call for around like personal health informatics, but I'm framing it as a personal health informatics, but menopause is in there, but it's not at the forefront. You know what I'm saying? And so even for like cancer research, how can we do cancer research for women, maybe breast cancer or what types of female cancers, but menopause is in there because that's kind of a forgotten thing that you're going into surgical induced menopause. And so there's ways I'm hoping we can use the current mechanisms to have it in there, but not at the forefront, so to speak, until we can get better mechanisms of funding. Yeah.
Yeah, I agree. How about wearable data and integration into the EHR? I know we talked about this before when we talked, but I think one of my frustrations is like patients are capturing great data right now with their wearable devices, and like Oura rings are incredible. But then when I talked with like our Epic team, right, like it's too much data to like bring in, and then they worry about like how we would respond if something is wrong. What are your thoughts on the wearable data and like that gap in healthcare?
Yeah, and I just read an article the other day. I just skimmed the top part of it, but it was really that we're at this inflection point, I think, where we have so much wearable data, but our health system infrastructure is not ready to support it. But yet that line is getting more and more blurred because, like you said, we're collecting a lot of data, specifically on women's health, the fluctuations that we won't see necessarily during episodic care that are so very important to understanding, I think, down the road, potentially risks, all these other components. I think we're going to have to figure it out at some point. I know the EHR systems currently, we're trying, I think there's pockets of it trying. But again, they're not set up yet. And then I too worry, like I've heard from clinician colleagues that say like, well, I don't want all that data thrown at me because if I miss something, who's liable? Yes, it's super important. Yes, I'd like to see it, but I don't have time. There's lots of barriers. And so until we figure out a better, I hate to keep saying workflow, but really it's the integration of that. And I think from also the study that we did from providers' perspective is that they're wanting it, but the infrastructure is not there yet. And so I think we're really at that point where we have to start figuring it out. I think it's going to get smaller and smaller, hopefully. But if we can do it where it's safe and it's effective for the patients and providers, and again, legally, I think that there's a huge piece of that. I mean, even with AI, there's legal components. So we're going to have to really, I think, somehow address it, but it's coming, and I think the consumer demand is there for sure.
Yeah, yeah. And then my last question is, let's see. Oh, okay. So there is a kind of a question in the chat. Nico asked, "Thank you for your amazing work and results. I appreciate you sharing it with us. I learned that Melinda Gates just donated millions of
Mhm.
dollars, or yeah, millions of dollars to work in menopause. Are you in contact with the organization to extend your awesome research and findings so more women can benefit?"
Yeah, thank you for that. Yes, I did see that from Melinda Gates. It's a huge donation. I mean, it's a tremendous, I think, infusion that we needed. I know that there's a big chunk that also went to the Menopause Society to really start to educate medical students around menopause and kind of integrate that, not only the Menopause Society getting some education modules, but even how do we infuse some of this curriculum into medical schools, and even I would say nursing schools for nurse practitioners and midwifery students is needed as well. But yes, I've been in contact with a few individuals, specifically, and I'm going to blank at the name at the moment, but a society. Oh, I'm going to blank on it. But yes, I know ways to start to try to get into that, and also hopefully looking for specific calls that they'll put out for the general public to apply for some of the grants that might be forthcoming. So super exciting work and amazing that she was able to donate that much money. Awesome.
Yeah. Yeah. When you look at standardized data and we talk about like individualized, whole person care, but then like standardized data, sometimes I feel like there's a little bit of a rub there.
Yeah.
How do you still provide that while acknowledging like the variability between women? And like, what if their answers don't meet like the standardized data set answers available? How do you capture that?
Yeah, and you always hate to use like the other box because that's where so much richness can get put in. And that's where it was really eye-opening, I think, trying to look at what are the validated tools that we currently have and how do they match with what we currently have for standardized terminology. And semantically, it's very hard just to make sure we're capturing all of it. And so I think it's an iterative process, and I think it's going to have to take a while to get to where we have something that is somewhat reasonable that we can capture 99% of it. I think that would be ideal. I know there's always going to be unique variances. We're unique individuals and we're unique people. But I would say too, trying to capture anything and have some sort of structure to what we don't have currently will be better for in the long run. But knowing that it's going to be certainly an iterative process, I'm super excited to try to even get my brain around having some sort of common data elements for across in clinical practice, but also research. Like how can we then marry these two things, research and clinical? We use real world data, but then we're also collecting it through research as well. So yeah, it's a conundrum because you don't want to put everybody into these buckets, but yet that's what standardized terminology and data does. So I think And there's also, I think, a future for AI in that world. And so we are looking at some semi kind of automated processes for mapping, data to standardized terminologies. It's not perfect, but it also could be faster than a human manually mapping because it's very labor intensive. Thank goodness we have PhD students and other colleagues that are interested to help us do this work, but because it can be very tedious. And I think you need more than one eye on it, which is very eye-opening. I might look at something differently versus someone who's in clinical practice day to day may say that does not match at all. And so I think it's certainly an interdisciplinary effort, but I'm hopeful that we can continue to try to get some sort of grasp around it. But yeah, it does feel a rub, but I would say that trying to do it better than having it just kind of the wild, wild west is what it feels like right now.
Yeah, absolutely. Ruby said, I imagine there's a tipping point using wearable data and getting overly obsessed with worrying about abnormalities. How do you advise patients to look at more data over time?
Yeah, great question. And I think there's a whole nother lesson on how do we, there's the idea of the AI empowered patients now, not just patient engagement, but we have AI empowered patients that are using all these LLMs. But I think too, it's really, again, it's that counseling that we can have is that it's over time. If you have one day that you're more stressed out and you see that you're getting stress warnings or you're getting my error warnings to stand up half the day, but it's, every day is going to be different, but it's that trend over time. If you're trending more and more healthy and you're more walking days and more active days than not active days, that's an improvement. I know that people can I need to get my steps in, and then they get overly obsessed if they're not on theirs. They have 10,000 or they have 8,000 one day versus their 10,000. And I think it's important. We're in it for the long game. That's the big thing is that, and movement is, if you're specifically thinking of movement or eating healthy, it's the long game. It's not just one day is not going to make or break it. And so we have to remind ourselves of that, that it's the trend over time that we're getting healthier or we're staying on a track. You may have days that you just cannot do it for whatever reason, and that's totally normal. That's life. And so to try to expect ourselves to be perfect every day is not realistic. You're setting a too high of expectations, and now instead of your stress level is going to go up versus you need to have a more of a balanced approach to it as well. So that'd be my take on it. Hard to do when you're trying to, you get excited about watching all your metrics, but certainly wanting to make sure you're maintaining health over time. Yeah.
Absolutely. All right. Any other questions? You can put them in the chat. Robin, do you want to tell everyone where to find you and your work and about your podcast?
Oh, yeah, yeah.
Can I just interject a couple questions too?
Please.
I actually had a very similar question to Amy's, but a little bit different, because when you were talking about unstructured versus structured data and all that, my thought was, well, are there some things that cannot really be quantified? And so if they cannot be quantified, can you put them into structured data? Are there any parameters that cannot? For example, right, we do pain assessments all the time.
Mhm.
You can ask a patient, is your pain, how would you rate your pain on a 1 to 5 scale or a 1 to 10 scale? So even though that's subjective, it's a subjective quantification. But are there some parameters that you don't think could really be quantified accurately or at all?
Well, being like a data person, I think everything's quantifiable, but I guess I'd have to have more of an example, but I think I would say sometimes I think it's challenging when we're thinking of like the contextual factors of where someone is their living circumstances or the environmental factors, I think are harder to quantify. Specifically, like the home environment that they're in may be more stressful, and how do you quantify that? Or it's maybe the environmental impacts that they may live where they're living. It's harder to kind of capture that data on a consistent basis unless we're asking for it and we have a way to enter it into the data versus like in a note field, you know what I mean? But you can't capture everything. It can't always be not everything can be forced into a structured field based on our current health systems that we have. But I think that there's opportunity. I'm hopeful that I think some newer technology is on the horizon that will allow us to integrate more of these pieces that I think are harder to integrate into current care. And I think specifically of the environmental factors that we have spoke about. So yeah, I think it's harder and there's more challenges, but I think we're whole human beings, and I'm hoping that that's, if we're trying to move towards whole person health, that would be part of it as well. They started really trying to get more solid data, like specifically social determinants of health. Before, that was a very kind of abstract idea, and now we have more specific ways to kind of integrate that and document that for patients. So I think that we could do that eventually. Yeah.
So as AI gets better, then that will be more possible to encompass more parameters, including like the environmental stuff you mentioned is like a perfect example of what I was talking. And I have one other question too, is that I've read over time that menopause is experienced radically differently in different cultures. And so, in fact, in cultures where women are revered and older women are revered, they have much, much less. I mean, menopause is like no big deal to them.
Right.
And we in the West here, and especially in our country here, have just the opposite, really, kind of things.
Right.
And so my question is, have you thought about, or are you able to like do the cultural incorporate the cultural differences into your thinking about how to do the tech assistance and so on?
Yeah, absolutely. And I would agree with you that I think there's various experiences that are very different, and we haven't been very great at capturing what that is. And so some of the previous studies, specifically the Women's Health Initiative and others, weren't as diversified as we should be. And so I think just acknowledging that part, and that we can do much, much better, and we can collect better data now that we have, we can move forward in a better way. I would say that's more inclusive. But I would say too that I'm hoping that through some of these newer technologies that we have the better ability to capture some of that data. I have other colleagues that are doing amazing work, Lisa Taylor Swanson and Jamia Cortez, at various universities, really working on specifically the diversity perspectives and diversity, I think, outcomes for women during midlife. And I would agree. I think the part that we don't necessarily talk about with other cultures that are older adult women are revered, and I think is the social connection component and the social, I think, acceptance component that we don't necessarily address. Whereas I think in the Western society, we medicalize everything very, very quickly. Which is fine in some regards, but I think that there's also a component that we really haven't necessarily addressed as we have much so in other cultures. So there's I think a lot of room for that too. And I heard menopause being talked about the other day about as the money pause, meaning because we're medicalizing it, but also there's every supplement under the sky now to help with menopause, and maybe it may or may not be the greatest thing, but a lot of money is being targeted at midlife women to help with this, and as the be all end all, which I just say as a word of caution. But certainly there are things that can be done, but I think it's just be cautious of all of that as well. So yes, I think there's a lot to work.
And also, like in our society, age is not revered at all. It's just the opposite. Youth is what's held up as the standard, whereas traditional cultures, and even in places like Japan and, where older people, or China even, and traditional tribal cultures, and it's such a different attitude toward
very much so
age and older.
And I'm hoping by bringing these conversations more out into the public, and the menopause now kind of being on almost every headline, it feels like that we have the ability to kind of open the door for more conversations that are inclusive for all, I would say, as well. And so and I think too, of, I'm a Gen Xer, and so Gen Xers, we're not taking this anymore. And so hopefully that we can, I think, have more open, broader, transparent conversations for everybody to enter into it, wherever they're. So I'm hoping that will change.
Okay, thank you. Looks like the screen is frozen again. I don't know if Robin, are you there?
Oops, I think I'm back now. Sorry about that.
Okay. You're okay.
Okay. All right. And I guess too, my email I put in the chat, and then thank you for sharing my podcast. It's called Midlife Unmasked. We talk about topics just like this, kind of across the board with various providers and others in the midlife space. So I'm happy to take a listen. And thank you again for the invitation. This was really fun. I appreciate it.
Yeah, thank you
Thank you
so
so
much.
much for
Thank you for
coming. Yeah.
a great presentation.
Yep. Sorry again
Thank-
about the technology issues this evening. I'll chalk it up to the hot weather.
You're fine.